I'm grateful to John North for the opportunity to speak today on clinical decision making. How can we do it better? I praise John's leadership and his duration of involvement with the Queensland Audit of Surgical Mortality. This important peer-reviewed educational activity has demonstrably improved clinical outcomes for surgical patients in Queensland. John's tenacity and integrity are key to ensuring the trust and continued participation of Queensland surgeons in this activity. I note and commend the participation of so many from a variety of backgrounds in this activity today, united by a common focus on improving clinical decision making. I have been privileged to chair the Audit Committee of the Royal Australasian College of Surgeons as a vascular surgical specialty elected councillor. I acknowledge from the outset also the leadership and commitment shown by Professor Guy Madden, Jepson Professor of Surgery in Adelaide, and his Audit of Surgical Mortality team, ably led by Wendy Babbage. The topic of my talk is Charybdis, Scylla, and Iatra, which translates loosely to the dilemma of being torn between unpleasant choices. The scope of my talk will briefly encapsulate a description of the three Greek nouns. I'll present a case with which I was involved. I'll highlight the most recent of the national case note reviews, and I'll close with a series of recommendations with common themes from the audits of surgical mortality. The dilemma of unpleasant choices, being caught between a rock and a hard place in colloquial terms, is a recorded condition of humankind from time immemorial. It's been very well captured in Homer's Odyssey, in the segment of that Greek epic which depicted Odysseus's return from the Trojan War, when he was transiting a treacherous narrow strait in his ship with, on the one side, shoals and on the other, a vicious whirlpool. He directed his helmsman to steer closer to the former hazard, potentially representing less threat to himself and his crew than the risk of being caught in the whirlpool with inevitable loss of all hands. Scylla is depicted as a six-headed monster with 3 rows of teeth on each jaw, devouring those who pass too close. Charybdis is a giant whirlpool, a vortex drawing all surface craft deeply into the depths of the ocean. The mythology may well be based on fact and is thought to represent the treacherous shoals on the western shores of Calabrian Italy, with the complex flows of large volumes of current transiting between the Ionian Sea from the Mediterranean and the Tyrrhenian Sea to the north through the narrow Strait of Messina. Constant reference to this series of difficult choices is recorded. And here we see a political satirical cartoon featuring the difficult choice of the British population sailing towards a utopian ideal. The vessel of the Constitution is trying to steer clear of the rock of democracy and the whirlpool of arbitrary power. This is somewhat akin to the surgeon trying to steer a path with the patient toward an optimal outcome. Perhaps on the one side, there may be patients with demands of the surgeon, not necessarily in the best interest of the patient. On the other, it may be fear of medical legal consequences that causes the surgeon to act in a way counter to the optimal patient outcome. The third Greek noun is loosely derived from the professional who accompanied Greek soldiers and withdrew arrows or spears from injured hoplites. Translated loosely, it means arrow puller. Bedeviling a lot of optimal surgical outcomes are the unintended consequences of surgery, either direct or indirect, but they're always unintended. Hence the reason then for the title. The inclusion of the two terrors, Charybdis and Scylla, and the third Greek noun, iatra, with their three-letter abbreviation CSI. Contemporary assumption of crime scene investigation is a double entendre far from the mind of the surgeon who embarks on the journey in good faith to deliver optimal outcome to the patient. By way of full disclosure, I acknowledge a recent fatal outcome at my own hands involving an 82-year-old male widower. He'd lived independently in a small coastal town south of Sydney till just a few weeks prior. At the insistence of his daughter, his only child, she in good faith had arranged his admission to a residential care facility in Sydney closer to her. In that facility he'd become less mobile and developed necrosis on toes of his right foot. He was transferred under my care to a vascular surgical ward. He had an infrarenal aortic occlusion with contiguous occlusion of the right common and external iliac artery and significant disease in the left iliac system. Comorbidities were significant, and they included ischemic heart disease, chronic renal failure and chronic obstructive pulmonary disease. His daughter became increasingly distressed, seeing the progression in necrosis of toes of his right foot. He'd become agitated by the pain, which was associated with even gentle dressing change, and the additional development of right-sided pretibial ulceration produced increasing alarm in his daughter. He was clearly a frail, elderly man who'd become largely immobile in a very short space of time, having enjoyed previously a very independent life till the transfer to Sydney. In part, feeling some guilt, the daughter was keen for intervention on her father, even in the face of the detailed and thorough explanation of potential risk associated with intervention. Cardiology review and anaesthetic review had identified a high risk for poor outcome, but with the patient's concurrence and at the daughter's insistence, surgery was undertaken. I performed a right axillofemoral bypass graft, technically a routine procedure, and it was associated with minimal loss. Planned extubation, however, at the completion of the procedure became less an option as cardiac instability supervened. Inotropic medication was commenced by the anaesthetist and the patient was transferred, ventilated, to intensive care. Discussions then with intensive care specialists, the daughter and myself resulted in limits of care being agreed. As increasing dosage of inotropes were administered, renal failure worsened and a cardiac dysrhythmia culminated in absent cardiac output. Life was pronounced extinct with the endotracheal tube in situ and his daughter in attendance. Although the daughter was grateful for the medical support and for her father's freedom from pain in his final hours, his death was clearly a consequence of my decision to operate. This form of medicalised death is common amongst the audits of surgical mortality. Now, the narrative in my description tilts in the direction of justifying the daughter's decision and defending my selected course of action. Arguably, neither of these acts magnified the final phase of this man's life and rightly should form the basis for self-reflection, but should occur with much less frequency than is the case in the current body of work of the Australian surgical audits in all jurisdictions. I do want to highlight now the National Case Note Review booklets. The last of these was volume 17 and appeared in May of this year. The detail included in each of the cases is considered at a level that allows for system improvement if the lessons are incorporated in daily clinical practice. Most clinically practicing surgeons can easily relate to a number of the cases present, and many, I'm sure, think, there, but for the grace of God go I. Case 1 is an admonition to avoid secondary iatrogenic injury. Case 2 highlighted a technical focus on pathology and surgical treatment. The fatal outcome could reasonably have been predicted and avoided, and arguably a more dignified passage to death would have occurred had a greater opportunity for significant conversations with loved ones before death. The final two cases of the series presented again highlight doctor-induced complications, which often add significant comorbidity and frequently contribute to surgical death. Deliberative reading of reviews such as this can help to avoid these poor judgment consequences. Now, unfortunately, lapses of judgment beset us all. They can lead to delays in patient treatment, to prolongation of hospital stays, to redo surgery, or to fatal outcomes. Failure to engage senior surgical input can be disastrous, and earlier recourse to seeking that senior input can frequently reduce poor judgment. Patients deserve, and the community expects, surgeons to consult, to participate and to direct the care of complex patients with multiple comorbidities. Communication failures are common to a number of the cases in the surgical audits. The frequency with which communication issues are reported by surgeons is least from within the complex environment of the operating theatres. A great number are reported from the preoperative phase and an even greater number in that post-operative phase. Ways of mitigating some of these lapses in communication relate to improved accuracy in handover and reporting. The implementation of standardised handover tools such as SBAR demonstrably minimises communication gaps. Within the complex surgical procedures, structured points of communication at critical junctures reduce distractions and minimise miscommunication. From the aviation milieu, the concept of a sterile cockpit where people are focused reduces distraction and enhances understanding at critical points. A common theme in these communication gaps are the deteriorating patients, particularly those in intensive care, where the surgeon's not contacted. Ways around that include a greater presence of the surgeon or the surgical teams consistently, regularly and frequently reviewing their own patients post-operatively in that ICU environment. And that includes a physical examination and the assessment of all relevant information. In some centres, surgeon engagement in these shared surgical ICU ward rounds goes a long way to improving communication. And in a number, a range of automatic triggers exist where mandatorily the consultant is notified if threshold physiological parameters are breached. Within the intensive care, the terminally ill patient often has decisions made in the absence of the consulting surgeon. And frequently we see this difference in professional bias between surgeons and critical care clinicians play out with decisions relating to the near-dead patient. It's important that each party seeks to understand the perspective of the other, and to aid discussions, maintaining that patient-centred focus is key. With critical discussions involving the family, the surgeon should be present, not a delegate, and ideally the timing of these significant communications with the family should be to allow the consultant surgical presence. A common theme in bad outcomes are the issues of frailty and obesity. In this forum, it's appropriate to highlight the paramount requirement to document height and weight, particularly in the period immediately prior to surgery. Paradoxically, some patients with large body form are extraordinarily frail, and conversely, some who appear wiry and who are interpreted to be frail can be extraordinarily resilient. But what is clear is that identification of patient fragility or frailty with a range of well-validated assessment tools should be a mandatory part of preoperative assessment, and indeed a fundamental element of the admission process to a hospital bed or a surgical ward. Nevertheless, it is still the case that in far too many operations, patient frailty has not been considered. In this forum, I acknowledge my sentinel failure to pay enough regard to the patient that I presented in terms of frailty. Complex cases are best served with a multidisciplinary team approach. There needs to be robust decision making where that process is transparent, it's accurately documented and communicated. The clinical context of the patient situation must be fully appreciated, and all of the relevant clinical facts need to be put in front of the multidisciplinary group as a paramount requirement for providing high quality care. This multidisciplinary approach should allow equity across colleagues and specialties with effective communication between all parties. With the actual provision of intervention, a consultant surgeon needs to be physically present in the theatre, especially during these complex cases. They need to be able to intervene directly and to provide their expertise, their experience and learning to junior colleagues who are still developing their surgical expertise. I would gently suggest also that a review of outcomes should be part and parcel of the audit processes of a surgical group. Some of those are rendered a little dysfunction because of intra-team dynamics or domineering personalities. In these settings, it's particularly important to consider the benefit of an external facilitator or external auditor, for this may allow the opportunity for a more open discussion and a different perspective on a poor outcome. Documentation. Lack of well-kept medical records is a recurring problem identified by the audit. Although all of us try to pursue high-quality communication, it's an area that still needs constant attention. Poor communication does not always lead to disastrous outcomes, but it is often a significant contributing factor. The hospital environment has become increasingly more complex for the admitting medical officer. Rosters now are often substantially shorter than in the past, and consultant involvement is often fragmented, particularly within public hospitals. The need, however, to coordinate the team is a vital role for the AMO responsible. High-quality medical records are vital both for the care of the patient but also to support a defence in medico-legal litigation. The best way, arguably, to ensure a coordinated team approach hangs off coordination, communication, record keeping or documentation. And this will go a long way toward ensuring that the team responsible for the patient is fully informed and that optimal management is occurring. In conclusion, I commend the activity of the audits of surgical mortality and all those who participate. Australian surgeons have generously and initially voluntarily participated in what has now become a mandatory requirement, the provision of information relating to deaths following surgery or associated with surgery. The trust in which this information has been provided and handled has in the main fostered an ideal environment for reflection, analysis and improvement. This open, peer-reviewed process has delivered an objective reduction in surgical deaths in all of the jurisdictions in which the audit of surgical mortality has been operational. Nevertheless, much remains to be done, and unfortunately it is still the case that repeated patterns of preventable errors culminate in preventable deaths, hence the rationale for meetings such as this. And I close again with gratitude and commendation to Dr. John North. Thank you.